Welcome to The Explainer. Today we're breaking down a core topic in cardiology that every single trainee needs to master, the diagnosis and management of stable angina.
So here's our game plan. We'll start with the fundamental definition. Then we'll walk through the entire diagnostic pathway. After that, we'll cover the go-to medical therapies and talk about when things like stents or surgery come into play. And we'll wrap it all up with a super high-yield recap to really nail down the differences between stable and unstable syndromes. All right, let's dive in.
Okay, first things first. What are we really talking about when we say stable angina? It sounds basic, but getting this definition right is the foundation for literally everything else we're going to discuss.
The one word you need to burn into your brain here is predictability. We're talking about discomfort that shows up reliably. Your patient says, every time I walk up that hill, I get this pressure, and as soon as I stop, it goes away. It's reproducible. And that's happening because a fixed, stable plaque is narrowing an artery. When the heart works harder, it demands more oxygen, and that narrowed pipe just can't deliver. It's that classic supply-demand mismatch.
And this right here, this is probably the most critical distinction you have to make as a clinician. Stable angina is predictable. Unstable angina is all about change. It's new, it's happening at rest, or it's just getting way worse way faster. That change is a massive red flag. It suggests that a plaque might have ruptured, putting the patient at immediate risk for a heart attack. It demands a completely different, much more aggressive approach.
Okay, so you have a patient whose story sounds like stable angina. How do you actually confirm that suspicion? Let's walk through the systematic pathway we use to work these patients up. The workup follows a really logical progression. You always start with the patient's story. That's ground zero. Then you figure out their baseline risk, and only then do you start bringing in tools like a resting ECG and maybe a stress test to gather more objective data to guide your decisions.
And let me tell you, before you even think about ordering fancy tests, a detailed history is your most powerful diagnostic tool, bar none. You have to pin these details down. What does it feel like? Where does it go? What brings it on? What makes it stop? These answers are the puzzle pieces that build your clinical picture. Now here's a huge clinical pearl. Not everyone reads the textbook. You have to be on high alert for atypical presentations, especially in women and in patients with diabetes. They might not get that classic chest pain. Their anginal equivalent could be sudden shortness of breath with activity, or just overwhelming fatigue. You can't afford to miss these signs.
So what about the stress test? When is it actually helpful? Well, the evidence is pretty clear. It gives you the most diagnostic bang for your buck in patients with an intermediate probability of having coronary artery disease. Why? Well, in a low-risk patient, you're more likely to get a false positive. And in a really high-risk patient, you might just skip it and go straight to an angiogram. It's all about that middle ground.
All right, we've made our diagnosis. Now it's time to talk about treatment. And the absolute cornerstone of managing stable angina is what we call guideline-directed medical therapy.
This is one of those takeaways you just have to know cold: aspirin, a statin, and a beta blocker. This is the foundational trifecta, and it's so important to remember. These meds are doing two jobs. They're controlling the patient's symptoms now, and, just as crucially, they're preventing future heart attacks and strokes down the road.
This table is basically your anti-anginal toolkit. You can see how each drug class attacks that same supply and demand problem. Beta blockers are first choice. They reduce the heart's oxygen demand by slowing things down. Others, like calcium channel blockers and nitrates, work on the other side of the equation. They increase oxygen supply by opening up blood vessels. And definitely look at that key clinical pearl column. Those are the practical tips like titrating a beta blocker to a target heart rate that you'll use every day.
So, beyond controlling symptoms, we have to protect the patient long-term. That's where these meds come in. Low-dose aspirin helps prevent clots. High-intensity statins do more than just lower cholesterol. They actually stabilize the plaque itself, making it less angry. And ACE inhibitors are especially key for patients who also have conditions like diabetes or kidney disease.
So this brings up the big question, right? What about stents and bypass surgery? Let's get really clear on the role of what we call revascularization when we're talking about stable disease.
This is a fundamentally important concept, and honestly, a common point of confusion. For a stable patient, unlike in a heart attack, the goal of an invasive procedure is not to save their life. It's to improve their quality of life. We do it for patients who are still having debilitating symptoms, even when they're on all the right medications.
Let me say that again, because this is a critical point that gets tested and misunderstood all the time. For stable angina, putting in a stent is a therapy for symptoms. It does not reduce the risk of death or future heart attacks compared to medical therapy alone. The medications are what provide the mortality benefit.
So if stenting is just for symptoms, when do we consider the much more invasive option of bypass surgery or CABG? Well, the guidelines point to very specific, high-risk situations that are all about the patient's specific coronary anatomy.
Generally, we prefer bypass surgery for patients who have really extensive disease. We're talking about a blockage in the left main artery, the big one, or blockages in all three major vessels. And it's especially preferred for patients with diabetes and multi-vessel disease, because in these specific groups, CABG has been shown to improve long-term outcomes, including survival.
Okay, to bring this all home, let's put everything side by side. This final comparison is going to lock in those critical differences between a stable and an unstable clinical picture once and for all.
This table really just tells the whole story, doesn't it? On one side, stable angina, a fixed plaque, predictable symptoms, normal cardiac enzymes, and our main goal is quality of life. On the other side, acute coronary syndrome, a ruptured plaque. It's an emergency, the symptoms are new or worsening. Biomarkers are often elevated, and our goal is totally different. It's about improving survival and saving heart muscle.
Look, if you remember nothing else from this explainer, remember these 4 points. 1. Stable angina comes from a fixed blockage. 2. Diagnosis starts with the patient's story. 3. First-line therapy is that 3-drug combo: aspirin, a statin, and a beta blocker. And 4. For most stable patients, stents are for symptoms, not survival. Master these, and you have a rock-solid foundation.
And that's what it all comes down to, right? The next time you're faced with a patient with chest discomfort, you now have the framework to figure out, is this a stable syndrome or is this an acute emergency? Applying these principles is what excellent patient care is all about. Thanks for joining this explainer.